Hello, everybody. My name's Connie Van Egan. I'm at the Division of Public Health at the Larner College of Medicine at UVM. We are kicking off our spring semester today with a discussion on the cystic fibrosis research model, success through a national therapeutic development network. We are inviting Dr. Charlotte Teneback today, who's an associate professor in medicine in pulmonary and critical care. She is the co-director of the UVM Therapeutic Development Center, the director of the Vermont Adult Cystic Fibrosis Program, and the co-director of our new bronchiectasis, I knew I was going to stumble over that, and non-tuberculosis myobacteria care center. She completed her medical degree at the Medical University of South Carolina, internal medicine residency at Dartmouth, and pulmonary and critical care fellowship here at UVM Medical Center, and joined the faculty after completion of fellowship. So, Dr. Teneback, will you take it away?
Thank you. Thank you for that introduction and for the opportunity to speak here. I know this is sort of a little broader audience, and so please feel free to let me know if there's something that I'm not sharing at the right level and it's not clear. Just let me know, and I'm happy to kind of expand as I go along. But I want to talk about sort of this amazing progress that's happened in cystic fibrosis. Really in the last 6 or 7 years, how that was able to happen and where we think that we're going next. I do have some disclosures. I do have clinical trial support from some companies that I'm going to talk about, and I have research support and clinical care grants from the CF Foundation and the TDN. So in order to kind of explain how the medications work, I'm going to spend some time also talking about the pathophysiology of the most common types of mutations in cystic fibrosis, the effect of the modulators on key outcomes, talk about the clinical trial network and how that was facilitated to get this kind of work done in a relatively rare disease. And again, talk about sort of our future needs and where we hope to go next. But I'm going to start with a case, just to put it into some clinical context. So this is somebody from our clinic. When I met him, it was back, let's say probably around 2009, 2010, when he was 20 and he was transferring to us from the pediatric program. He is homozygous for the F508del mutation, which is the most common mutation in cystic fibrosis. About 50% of patients are homozygous and about 90% have at least one copy. Sweat chloride diagnosis was very high, 121. Normal is less than 30, and the diagnostic cutoff for CF is 60. His lung function at that time, we measure the FEV1, which is the volume of air exhaled in the first second of a forced exhalation. This is sort of like our blood pressure measurement in CF. It's like the way that we follow lung function. And normal has a wide range, like 80 to 120%. He was at 55, which is, definitely reduced. He was chronically colonized with multiple bacteria, which are associated with worse outcomes. He also had this kind of traumatic history of having had an older brother who died from complications of CF when the brother was 21, and that was 4 years earlier. You can see from his complications that it's sort of, CF is a disease that affects the whole body. So this mutation is in epithelial cells, so it's going to affect anything from the sinuses, the GI tract, the lungs, absorption, infertility in men is almost universal. And so you can just see by his complications, he's got all the complications in all the organ systems where we see cystic fibrosis be active. And plus he'd had some issues with PICC lines, are these tunneled IV catheters that we use for long-term antibiotics. And those have become very difficult to place in him. And he'd also had some blood clots associated with them. These were all his medications. So vitamins, chronic antibiotic as an anti-inflammatory, treating heartburn, allergies, pancreatic enzymes to replace the ones that his pancreas couldn't make, ursodiol to help protect the liver, sinus rinses, and an inhaled antibiotic. He also had this very tedious airway clearance regimen twice a day, albuterol, nebulized saline, nebulized Dornase alpha to break up the mucus, and then vest therapy to try to get the mucus out. So you can imagine this is taking like hours a day for people to do all these treatments. But this is sort of this was a standard regimen in CF. But going back a little bit, I want to talk about sort of how it all started. So meconium ileus is a bowel obstruction caused by mucus in neonates, and that was actually first described in 1905. But cystic fibrosis was really identified by Dorothy Anderson in 1938. It's a kind of an interesting story. She wanted to be a surgeon. They said, no, you're a woman. Women can't be surgeons. She became a pathologist. And she started to notice this pattern of cystic fibrosis in the pancreas of young children who had died of malnutrition and pneumonia. So she wrote the first paper on this, and she realized this was something different that had their malnutrition at the time was being attributed to celiac disease. And at that time, the only way that they made the diagnosis of cystic fibrosis was if a child in a family died, had a characteristic autopsy, and then a subsequent child in the same family had similar symptoms. So that's pretty morbid. But that's how they diagnosed it. But in 1948, Dr. Anderson and another physician in New York saw that all these young babies that were coming in during a heat wave with heat exhaustion had a very high skin chloride. And 10 out of the 12 cases were in children who had this diagnosis of CF. So they realized that there was a connection there. And based on that, they were then able to develop the diagnostic sweat test, which is still really the standard for diagnosis that we use today. But CF was really devastating. Even with being able to diagnose, these babies died very, very young. Malnutrition and pulmonary infections. And in 1955, the CF Foundation was formed, and it was formed by parents of kids with CF who felt like they had to do something. And this is a remarkable start. You know, they fundraised, they formed this organization, and they set us really on that pathway that got us to where we are today. This is a map of the CF care centers in the US right now. You know, when they started out, it was one center. It spread to 2 centers. And now we have, I don't even know how many this is. It's over 100, I think. You can see these blue dots are proportional to the size of the care center. We're up here, we have about 150 patients total between adult and pediatrics. So we're not that big. You can see there's a lot of larger ones. But we are accredited through this network, and we benefit from, you know, a range of resources that they help us with, including like a patient registry that has data on over 33,000 people with CF in the US. And it became clear very early on that having specialized care centers was linked to better outcomes. So these are survival curves for CF, and you can see this A is untreated. That's data from 1938. And so you could see that there were almost no kids left alive by the age of 10, and more than half died in the first year and a half of life. B, C, and D were cohorts a little bit later that had access to pancreatic enzymes to help their digestion and antibiotics. So that definitely helped. In E, you can see that these were kids that were followed. At that time in 1964, there were 31 care centers. And just by being followed at a care center, their survival was significantly better. they weren't getting any other treatment. And then F was sort of the best care center, Babies and Children's Hospital in Cleveland. And those kids had the best outcomes. So this care center model is definitely sort of well proven. And we made, some improvements. The sweat test was developed here, airway clearance, antibiotics, the pulmozyme, inhaled antibiotics. But it's really, and you can see like survival is inching upwards, but it still isn't that great. I think when I was in medical school, the average survival was 25 still. But it was really the identification of the CF gene that got us to where we are today. And this was actually, I think, the first gene defect that was identified as a cause of a disease. Today, this seems like so commonplace. We have all this genetic testing, everything's been mapped out. But this wasn't the case. It took them 3 years to identify this gene. They were finally able to map it to chromosome 7. So this was amazing work. It brought a lot of excitement. And they kind of like thought they had it in the bag. They're like, okay, we know the gene. Like now we can figure out how to fix it. And there was really like a sense that a cure was going to be not that far in the future at that time. That unfortunately did not end up panning out. So I want to talk a little bit about the CF gene. It's a transmembrane epithelial channel that transports chloride primarily. And in CF, this is either absent completely or not functioning. And that leads to a loss of chloride ions in the airway liquid, like in the lungs, in the liver, to whatever lumen it is, becomes sticky, making it hard to clear, and leads to sort of congestion in the lungs. It makes it a great habitat for bacteria. But it's the same kind of dehydrated and sticky fluid that causes obstruction, whether it's in the pancreas, the liver, the fallopian tubes, and so on. So the gene therapy attempts, there were many trials in the 90s and early 2000s, tons of challenges. They tried to use like adenovirus vectors. They didn't work. They weren't able to get good delivery to the airway epithelium. There was huge problems with immunogenicity. The gene expression was really transient. And then there was a big setback with this young man, Jesse Gelsinger. He didn't have CF. He was in a gene therapy trial for a metabolic disorder, which is a pretty severe disorder, but he was doing well. He was able to treat his disease with a restrictive diet. But he participated in this gene therapy trial and he died. And so that really kind of made people wonder if we should be doing this. And I think in CF, it became clear we needed to do something else. And so they started to look at molecules that could instead sort of change the function of the gene product. And so this diagram shows all the different classes of mutations. And so there's over, I don't know what we're up to, 2,000 something mutations in CF. They're identifying new ones all the time. And they're put into classes sort of depending on where they cause a problem. So class 1 mutations, no protein is made at all. And these are the ones that we're still really struggling with treating because there's no product to do anything with. It's usually premature truncation or sometimes nonsense alleles, and that's about 5 to 10% of people with CF. Class 2 mutations, a protein is made, but it's misfolded, and then it's just sent for degradation and it never makes it to the cell surface. Delta 508 is a class 2 mutation. So this is what most people have at least one copy of. And then we have these other mutations where some protein is at the cell surface, but it's either not staying open or it's not staying open long enough or it's unstable. And what they just, the first mutation that they decided to target with these small molecule therapies was one called G551D. It's a class 3 mutation, so there is a channel at the cell surface. It just isn't working. And about 4 to 5% of people have this mutation. So this was an early use of high throughput screening, which again is like pretty commonplace today, but it really wasn't at that time. The CF Foundation and the Therapeutic Development Network actually invested heavily in this work, in the companies that were doing this, to be able to make it happen. And there was a lot of work trying to figure out, like, what outcomes are we going to study? Like, what are we going to decide says that CFTR is working? And that discussion is to some extent still ongoing. But this medication that was developed, oops, sorry, my slides are not quite in order. But the other thing, in order to get this kind of work done, so we're talking about a mutation that 5% of people with CF have. That's like about 1,500 people in the US. So how are you going to do a clinical trial and be able to recruit when there's like, that's your population? So the Therapeutic Development Network had already been building, had been doing the other studies of inhaled antibiotics and other things. And so this network was able to pick a few big sites and have referrals, and actually were able to get the study done. We were not in this ivacaftor trial, but we've been in the subsequent modulator trials. So they were, through small molecule high throughput screening, they were identified this ivacaftor. It attaches to the dysfunctional protein at the cell surface, and it fixes it, and it makes it work. It increases its activity. It's kind of amazing. And it had just huge impact. So let me walk you through some of these panels. So lung function, like I talked about earlier, we measure in FEV1, the airflow in the first second. On the bottom, you can see that the placebo group really had no change. And the treatment group had almost like 10% improvement, which is huge. You can see that they had fewer exacerbations in the ivacaftor group. They had significant improvements in their symptoms. There's the CF-specific respiratory quality of life symptom scale. And they also had a significant weight gain. And weight is a big problem in cystic fibrosis because of the malabsorption. And low weight is strongly linked to lower lung function and worse outcomes. So this weight gain is a really important outcome. So there was huge excitement about this. This is a tattoo that a mom got when her daughter was able to go on this medication. So this is really exciting, but just for a really small number of people. So we needed something for everyone. And this is a sort of an overview of how the mutations kind of are spread across people with Delta 508. And so these numbers are always shifting slightly as we diagnose more people. And adult diagnoses tend to have more rare mutations, but, let's say 85 to 90% of people have one copy of F508del. So that seemed like the logical next thing to go after. And so as I talked about earlier, in the F508del mutation, the protein is misfolded and it never makes it to the cell surface. So they had to develop what we now call correctors to attach to the protein at an early stage and make it look normal enough that it wouldn't be sent for degradation, but actually make it to the cell surface. So they found a corrector, but by itself, it really wasn't able to do that much. But when they combined it to this potentiator, the ivacaftor that had already been developed, that seemed to make a big difference. So the first studies came out around 2015 of a corrector, lumacaftor, with ivacaftor. So we're using the corrector to get the protein to the cell surface, and then we're using that ivacaftor to help it stay open. And this was for people with 2 copies of Delta F508. But this data is really, this is lung function data. And you can see like this is a lot less impressive than the ivacaftor for G551D. So we got about like 3% improvement in lung function. Not super great. And even like during the extension study, it sort of dwindled down. But there was some improvement, fewer exacerbations leading to IV antibiotics. Those are important outcomes, but it was definitely not as good. And there were quite a few people that couldn't tolerate this combination drug. Chest tightness was a big problem, stomach pain, rash. So within a few years after, a kind of slightly improved version, tezacaftor, ivacaftor, came out. Similar efficacy, but better tolerated. But for that one, as well as the initial combination, like the lung function impact was really pretty modest. So if we go back to our patient, in 2015, he started on the first combination modulator that was available to him. He couldn't tolerate it. He had the chest tightness. And we definitely saw this more in people with lower lung function. He continued to have really frequent hospital admissions. His mental health started to decline. He was drinking more. That didn't help anything, obviously. And then in 2018, the tezacaftor ivacaftor combo came out, and he switched to that. He tolerated it, but he didn't really have a change in his clinical course. And this is what we saw with a lot of people. And his lung function actually declined into the 30s. And we started to have family meetings and talk about a transplant referral. So things were not good. And it was clear that as a society in CF, we needed something better than this. And researchers realized that if they used 2 correctors instead of just one, they were able to fix the shape of the protein significantly better. They realized there wasn't just one place where it was misfolded, there were 2. And combining 2 correctors with a potentiator ended up having a much bigger impact. And so these clinical trials, again, moved forward through the TDN research network. Over 1,000 people with CF participated in these trials. And we were a site for this as well. And this is a really nice thing to be able to offer to our patients, like to participate in a clinical trial. Even though these are placebo-controlled at an early stage, they all have open label extensions where patients get access to drug before it's commercial. And they studied this triple combination in 2 cohorts, both people who were homozygous for Delta F508, but also people with just 1 copy. And these people, up to this point, had no medications, like no modulators. And these results are really good. So there was a dramatic improvement in lung function, even better than ivacaftor alone in G551D. And sweat chloride levels dropped dramatically, such that many patients on this medication, their sweat chloride dropped below the diagnostic threshold for CF. So this was really amazing. And we also saw, really huge drops in exacerbations, huge improvements in symptoms. And this is the drug, the brand name is Trikafta, because elexacaftor, tezacaftor, ivacaftor is like a mouthful to say. We also abbreviated ETI. So our patient started taking this as soon as it came out in late 2019, and he had a great response to this. So you can see over time, this top line is his vital capacity, and this lower line is his FEV1. So these are both lung function measures. And these blue lines are hospitalizations. So you can see he was getting hospitalized all the time. He had 1 hospitalization where he went home on IV therapy after starting this, and then 1 more in late 2022. But I mean, this is amazing. Um, and similarly, we saw his weight really improved really significantly as well. So you remember all these medications that he had been on? He stopped almost all of them. He just takes his modulator therapy and pancreatic enzymes. This doesn't necessarily mean that this is the right approach. We've done some trials actually looking at the safety of withdrawal of hypertonic saline and Dornase alpha, which are now being called legacy therapies, amazingly. Um, but we don't necessarily recommend everyone stopping everything. But we have a ton of people like this that they just feel so well. As long as they take their modulator therapy, they're doing great. In kids, the pancreatic insufficiency actually sometimes reverses with treatment, and they don't even need pancreatic enzymes. So about a year and a half ago, a new triple therapy came out. This is being dubbed the Vanza triple. It's vanzacaftor, tezacaftor, an deuterated version of ivacaftor that makes it able to be taken just once a day. And this is, if you ever try to take a medication twice a day, like it's actually pretty hard. And significant number of people were missing their evening doses, especially. You have to take these with food and enzymes and like a significant amount of fat. So that complicates it further for people. Lung function effect on the Vanza triple is pretty similar to the previous drug, but the sweat chloride actually improved a little bit more, about 10%. When this came out, though, both ETI and the Vanza triple got black box warnings for serious liver damage and liver failure cases. There were deaths on ETI after starting, and they significantly increased the lab monitoring to monthly liver function for the first 6 months. And that doesn't maybe sound terrible to adults, but that can be a lot for little kids to get that many blood draws. So this is kind of a summary of the modulators, like where we are today and what percentage of patients are taking what. So you can see there's some age limitations to some of them. Something I'll point out, so when ivacaftor was approved, the studies only looked at it for one mutation. They only looked at it for G551D. It's now actually approved for 97 different mutations. And this was done, the approvals were obtained through in vitro testing, which is pretty unique. But the FDA allowed it because these other 96 mutations are so rare, there's no way you could ever do a clinical trial. And they actually acknowledged that. And they've allowed expansions of all these labels based on in vitro testing. There have even been some cases where they have, insurance has approved modulator therapy based on phenotyping. So patient doesn't have a treatable mutation. We get their tissue. It's actually often rectal cells that are sent to the lab, and then they study the cell's response to the modulator in the lab. And if it responds in terms of chloride conduction, there have actually been cases where it's been approved that way. You also see the cost. The cost is tremendous. I don't have the number of people who are on the most recent modulator here because that data for, it just came out at the very end of 24. And 2025's annual data isn't out yet. But I think it's going to be probably pretty significant. We're switching people over who were still symptomatic on ETI, who were not doing well, or who still have like a relatively high sweat chloride. So we've started to transition some folks over. So with these new drugs, the survival benefit has been amazing. Now I'll say this is estimated survival. So they do this in 5-year increments because there's year-to-year variability, but they're estimating that for people with CF born between 2020 and 2024, half are predicted to live to 65 or beyond. And this is really pretty remarkable. And I think in reality, in the US, if a kid is born with CF today and they have a mutation that there's a drug for, like they could have a normal lifespan as long as they have access to and tolerate that medication. This being said, the deaths that are occurring right now are still in younger folks. Like people are dying now, like in their 20s and 30s. And sometimes that's from complications of lung transplants or from refractory infections. Adults that develop significant structural lung disease, like a lot of scarring or cavities, they can only get so much improvement with the modulators. So it's not perfect, but it's an incredible kind of like goosebump improvement, I think. And so I wanted to talk a little bit more about the Therapeutic Development Network because it's really instrumental in getting this work done. And it was established in 1998 with support from the CF Foundation. At maximum, there were 91 sites in 44 states. They've actually pulled back a little bit. The reason why they're doing that is that the focus is shifting more and more to genetic therapies. And the goal is still to cure CF. We haven't done that. And they realized that, that's going to take a while. And the foundation wants to make sure that it doesn't run out of money until that's been able to happen. And so some of the TDN sites that have not been high performing or enrolling a lot of patients did get cut. There are some great resources like a protocol review committee that I served on. So any protocol that's proposed to be done in the TDN is reviewed and we make sure it aligns with the goals and that it's doable and that it would be safe for our patients. There's a steering committee that I'm on right now, and then a clinical research executive committee that sort of determines kind of like our path forward and the strategic plan. There are some great National Research Center cores that sites can work with. So, for example, like we've worked with the NTM group at National Jewish. We've done some work where they have genotyped our non-tuberculous mycobacterial samples in our patients and actually were able to figure out that we've had genetically identical clusters of infection, which is quite interesting. There's like the nasal cell serotyping where they do that testing for rare mutations. The Multiple Breath Washout Center in Toronto. So multiple breath washout is a type of breathing test that doesn't require any effort. And so it's been used a lot in kids with cystic fibrosis. You can't do regular breathing tests, which require really some coordination and effort. And so we do that in a lot of our clinical trials, and we've been able to send our coordinators to Toronto to get training. So that's just an example of one of the benefits of this trial network. So it is a competitive award, but we do get, I get 10% time, which means a lot to me. They pay for some coordinator effort. There's a lot of training resources for new coordinators, especially, and new PIs too. We have meetings twice a year and they pay for that. So like we're very well supported. It's a really amazing network in that way. We have these smart reports. So I talked to, there's a patient registry. And that data gets pulled into these reports. So we can say, if there's a new study recruiting and they say, do you want to be a site? And we look at what's the patient population, we can pull up a report and say, who at our center is potentially eligible to participate in this study? And that's hugely helpful to figuring out if it's a study that makes sense for us to do. Are we going to be able to recruit into this study? Because if it's a genetic study and we don't have a single patient that's eligible, right, that doesn't make sense for us to be a site. And they also give us some study metrics. So these are some examples. So in these metrics, every blue bar is a TDN site, and we're the yellow bar. We're combined with the Children's Hospital in this. It's sort of a joint adult and pediatric research site. And so on this graph, you can see weighted subject units as a percentage of our center population. And this is for 2025. And they weigh it slightly based on the complexity on the study. So like a really complex phase 1 is going to get a little more than an observational study, for example. And we actually were able to enroll 10% of our population. You can see that I think we're number 6. And I think that just says so much about people with CF that we take care of. And I think they're a big part of the success is they're very interested in participating. And I learned this really early on. As a new attending, I was doing this study where we were just collecting sputum samples to do something with. And I would just ask patients, like I have the consent form, like, are you willing to submit a sputum sample for research? And like, I think there was one patient out of like the 50 that I asked that said no. And that patient said no because they like found the consent form and the HIPAA language overwhelming. Everyone else was like, well, sure, of course. Like, why wouldn't I do that? And you can see here, we're actually number 2 last year for enrolling into interventional studies as a percentage of our population. So we're very proud of this. I have to even show this. In 2022, we were number 1. But we slipped a little bit, but we're still very happy. So how do we do it? I mean, the TDN support is a huge piece of this. Couldn't do it without that. We try to be very wise in deciding what studies we sign up for. You know, nobody wants to spend hours and hours on a study startup that doesn't enroll, right? That just doesn't make sense. We've also tried to really keep a broad portfolio. So we've done a lot of the modulator studies. We're actually doing a phase 1 right now, which is exciting. It's adult and pediatric. We've also done nutrition studies, treatment studies in terms of like, when do you start the antibiotics? Which antibiotics? How long? We're doing an anti-inflammatory study. That's a phase 2 right now. Observational and interventional, like not put all our eggs in one basket. We've also done a lot of work with trying to really integrate the clinical research into the patient care space. Our coordinators have done an amazing job with this. So we have a pre-visit planning meeting every week where we go over who's coming tomorrow, what do they need? Like CF care is very multidisciplinary. So we say like, do they need to see the respiratory therapist? Do they need to see the social worker? Do they need to, get a blood draw? And we put research into this. Do they need to see research? And a couple of years ago, we started this project to do annual research visits where the aim is to see every single patient, whether we think that they're, a good research subject, whatever that is, or whether we have a trial for them. The coordinator goes in, meets them, and they do education on a topic. And it's been like 1 year was like gene therapy. It's been phage therapy. So that they start to develop a relationship with the coordinator. That's so important because then when someone calls you and says, hey, we have this study, like they know who's calling. And of course, having it come from the physician is huge as well. But I think, honestly, the real secret sauce is the people, hiring the right people onto your team. This is Julie. She has been our primary CF coordinator for over 10 years, I think. She's absolutely amazing. She holds it all together. Nessie is one of our current research coordinators as well, really good. We're losing her to medical school this summer, and Zach's going to take her place. We have a regulatory coordinator that really helps because for a clinical research coordinator who likes spending time with patients, like the paperwork part can become pretty overwhelming. So having a regulatory specialist, and she doesn't just do CF, it's like probably 5 or 10% of her time, but having that has been really, really helpful. Abe is a physician assistant who's been in the CF clinic space for, I think, probably 15 years. Incredibly bright, started having 1 and then actually now 2 days a week dedicated to research. He doesn't just do CF research on those days. He's at the Vermont Lung Center, but he supports the CF research team there. And then one of the adult physicians is missing, Zach Weintraub, and then pediatric, Tom Lahiri, and then Jill Sullivan is a gastroenterologist who is a PI on some of our studies as well. So can't say enough about, hiring the right people for this kind of work. So what's going on with the pipeline? I mean, this is from a couple of years ago, but I think it's still largely true. A lot of different things are being looked at. There's still some work on anti-infectives. A lot of it's novel approaches like IV gallium, where we're also doing a phase 1 of using that for people who've been diagnosed with non-tuberculous mycobacteria. Gallium is really interesting because it looks like iron, which a lot of bacteria feed off of, but it's not. So they eat it thinking it's iron and then they die. So that's an interesting approach that's getting more attention. And then, phage therapy is also a hot topic. Phages are viruses that infect bacteria. So they can be used, to infect and kill bacteria in the lungs. Anti-inflammatories, this has been a topic in CF for a long time and nothing's really panned out. But we are now, again, we're doing a phase 3 study on that, but there is a phase 2 on a different neutrophil elastase inhibitor, specifically in CF as well. But most of the work is in restoring CFTR function. So for the people with the group 1 mutations, where no protein is made, there's still work looking at drugs that might help like read through or stabilize the mRNA so that the protein can be made. That's also hasn't been very successful. And then a lot of work on the genetic approaches. This is the TDN pipeline right now. So you can see how many genetic therapy trials are in the works. I mean, this is where the money's going. Many of these you can see are still in the preclinical phase. Nothing past phase 2 right now. And these are really tricky because, again, right now they're limiting these to people who aren't on a modulator therapy for safety reasons, and there's not that many. So the foundation and the TDN has developed a clinical referral network. We have a Northern New England group that meets monthly to talk about who's doing what. Like, you doing this study in Boston, we can send you this patient. And the TDN also has a referral coordinator. We are not a site for any of these. It just hasn't made sense for us, unfortunately. They're still, restoring CFTR protein function. So I put little stars by the ones that we're participating in, but this is still ongoing. And Vertex, which has made all of the modulators to date, has definitely been the main character. There's another company that's trying to get in on this space. Anti-inflammatory, anti-infective, and also nutritional studies. So there are definitely still, unanswered research questions as well. Like, do you use 1 or 2 antibiotics to treat Pseudomonas? When do we start them? Do we start them as soon as somebody feels like they have a cold, or is it okay to wait a few days and see if they actually get over the cold if they're on a modulator? It's safe to stop these legacy therapies. We see quite a bit of non-tuberculous mycobacteria in this population. We've been part of an observational study to try to get more data to figure out if we can learn when, like to sort of learn when the right time is to treat them with antibiotics. These antibiotics are really tough antibiotics. We're talking about like 3 to 4 drugs, sometimes IV, for an average of like 18 months. So this is not something that you're like, oh, let's just treat this. We have to like be really sure that it's causing disease. And then phage therapy too. So that is kind of like where we are with CF right now. I think we've made tremendous progress. This is from 10 years ago, but this was the guy that was on the cover when the gene was identified. And the goal for everyone in CF is that we're going to keep doing this until CF stands for cure found. That's the commitment. We don't want to leave anyone behind. We're thrilled how many people are doing well today. We're thrilled that they feel so good they don't want to come to clinic, although we still like to see them. It's been an amazing process to be a part of, to see this huge shift. But we know we're not done. Yeah, that is the end. I will stop sharing, and I'm happy to take any questions.
Great. And thank you, Dr. Teneback. That was really fascinating. I'm not at all involved in CF work, but you certainly have created an inviting and thoughtful space for people to ask questions. I see there are a few posted in the chat and that Gary has his hand up as well. Let's go ahead with Gary and then we'll go to the chat.
Yeah, first of all, thank you for a really informative presentation, and it is incredibly encouraging. I mean, the progress that's been made. The question that I had is that we're looking at a predominantly rural North New England population, where in many cases physician accesses primary care practices. Is there capability to be able to treat CF in primary care practices with a support system that's linked to the academic medical centers?
Yeah, I mean, this is a really good question. And the CF Foundation is actually doing a trial of bringing in primary care and providing some training. We're so kind of aggressive with antibiotics. It's very different. And it's not, we do a lot of like fluoroquinolones, for example, and things like that. So historically, like our practice has been very different, that we have asked our patients to sort of bypass primary care and just call us. But there is sort of a movement as they're coming to see us less. I think it's hard here because, well, I mean, there's so many primary care providers everywhere. We could work with an APP or a physician like at UVM MC, but our patients are coming from like upstate New York, northern Vermont. That's been really the challenge with that.
Oh, I can appreciate that.
It does sound like an appealing and interesting thing to explore as time goes on. Jan Carney asked, can you talk about insurance coverage, including Medicaid, for these patients and what the challenges are?
Well, when the first modulator for a broad number of people was approved, Tom Lahiri had to go meet with Vermont Medicaid executives to convince them that it was worth spending this money. And it was like, their argument was like, this is going to bankrupt Vermont Medicaid. It's a lot of money. But the counter argument is that it saves a lot of money with hospital admissions. The number of lung transplants has dropped off dramatically. So Medicaid coverage is actually pretty good. In Vermont in general, we've been lucky with insurance coverage overall. When I talk to like colleagues in other parts of the country, they have a much harder time. In general, if we can show that somebody has, some insurances will require proof of the genetics, that somebody has the right genetics for these. And certainly switching from ETI to Vanza triple sometimes, will require an argument of like, why do they need that one as opposed to the one that's slightly cheaper? The biggest barrier I think that's happening right now is a lot of people are facing some really high copays. That didn't used to be the case. And so the foundation actually, and there are other programs that offer copay assistance. We have some patients getting up to $20,000 a year in copay assistance. But it's going to be an increasing problem, I think. And you could talk a lot about the ethics of all of this. These drugs had a delayed distribution in many European countries as they negotiated price with the manufacturer. There are two countries. One is Argentina, and I'm blanking on the other one, where they don't have loss on like brand name. I forget what I'm trying to say. They were able to like immediately make generics. And so there are two countries that make generics. And I grew up in Sweden. And so there were people in Sweden that were flying to Argentina and buying a year's supply of Trikafta before it was approved in Sweden. I saw a patient from Canada who had fundraised to buy it because she couldn't get it through the National Health Service. So the financial piece is huge. We've been relatively protected here, but it's it's really like an ethical barrier, and there are a lot of people across the world who are being left behind from this progress.
Sounds like there'll be a lot of policy level work in the future on that. So thanks for that quick overview. We have a question. What are the challenges specific to patients in rural communities? And you've covered this a little bit, but are there particular barriers related to being in a rural community?
I think there are some. It's a lot of patients are coming long distances. We see this in pulmonary in general, coming. Northern New York is like a bit of a medical desert, There's very little specialty care. People are coming like 3 hours sometimes. I had patients even coming from the Albany area sometimes. And that's really expensive for them. I think that having telehealth has helped a lot. So we do a lot of telehealth visits with people who are very remote. It's, we're sort of somewhere in the middle, I guess, Like I think it's pretty bad here, but then I look at people in Utah and they have to like take a plane to go to CF clinic, So it's sort of like, yeah, it's not great, but
Just out of curiosity, how does telehealth work when you probably have to listen and, thump someone's back or something like that? Isn't there like a physical aspect to that visit?
yeah. So what the CF Foundation did during COVID was get home spirometry devices to pretty much all the patients so we can still get that lung function piece. Obviously, if somebody's not doing well, we want to see them in person so we can listen to them. But if it's sort of a routine thing, we're now sometimes able to just see them by video and go based on symptoms and their home testing. We're trying to utilize more local labs too. It's a little harder for us to track down the results, but it's so much easier for patients. So we're doing that.
That's really helpful. Yeah. Visits for a sick child are not easy. Erin identified that she understands that there are a number of CFTR-related disorders not meeting diagnostic criteria for CF. So are those modulators and other therapies being explored for other CFTR-related disorders?
Yeah, this is a hot topic. So the manufacturer, Vertex, that has these drugs is not exploring this. And my understanding is that it has to do with how they got the drug approved under like a rare disease, rapid approval kind of thing. But physicians are sometimes doing this. So I see a lot of these patients with CFTR related disorders. Many of them don't have a treatable mutation, first of all, so that limits it. But I definitely know that there are people out there. So in order to treat them, you would have to say that they have CF, otherwise it's not approved by insurance. But if you say, this patient has a clinical syndrome of CF, you can treat them. And there are people that are doing that. I haven't personally done that, but it's being done because the sense is that it probably does help. If someone's sweat chloride is 55 and you bring it to 25, they're probably going to do better.
And one last question, I think, and I'm going to refer you to the chat if you can see it, Dr. Teneback. Adriana Rosado has asked a pretty complex but important question. It seems that the introduction of CFTR modulators have decreased infections to pseudomonas, sorry,
Yeah.
you see that word,
Yeah.
and not major effects in MRSA, and what your explanation is.
Mhm. Yeah, I don't really know. It's very interesting. I mean, certainly staph is probably more prevalent in the environment. Um, I think we're also not, I mean, I'm personally not entirely sure. Like, we are culturing less Pseudomonas from people, but people are making less sputum. And then the question is, if we went into their lungs and got a sample, would the Pseudomonas still be there? Or is it actually gone? And I don't think we really know the answer to that. And now, the highly effective modulators came out right during COVID. So there were a couple of years there where people did really, really well because the isolation also helped tremendously. And so we're having people are getting a little more sick, they're making a little more sputum, but we're really working hard on also figuring out how to capture what sputum they're making so that we can answer these micro questions. I mean, it's really hard for me, like if somebody's sick, like the teaching is like you treat them for what they cultured in the last 2 years. And let's say that we haven't seen Pseudomonas since 2019, but if they don't respond to treatment for staph, I'm still gonna assume there's Pseudomonas in there. I know I'm not really answering your question. I don't know the answer.
It certainly adds to your comment that although there have been a lot of successes, there's still a lot of challenges, and that the
Yeah.
work is so important. I hope you looked at the other comments, Dr. Tenneback, because people found a whole lot of benefit, not only from your presentation, but the way you presented. And this has
Oh,
been
thank
very,
you.
very helpful. Um, is there anything else we should just share, Sheila, before we say thank you to everybody and sign off? Are we all set for now?
I think we're all set. I'm going to stop recording.
All right.